My talk is on update of exercise recommendations for athletes with ischemic heart disease, and there are existing recommendations, and we're going to talk about those in a minute. Initially we were hoping to present to you the new recommendations in their total, but they're not finished, so we have to talk about what can creep up in those recommendations. So the learning objectives, and as this is also part of the education in sports cardiology, there will be on the website these learning objectives. So we talk a little bit of the risk and benefits of exercise and physical activity, and this is very little because you all know this. But we also talk a little bit of why recommendations are needed, and also try to be familiar with the current exercise recommendations. And what's happened since the recommendations in 2005, and also be aware of the rationale behind these updated recommendations. So first of all, the risk benefits of physical activities, there's no doubt, of course, the physical activity is good. That includes people with or at risk for or with ischemic heart disease, of course. This is very important treatment modality and prevention modality for these patients. But there may be an upper limit for the positive effects. Too much might be not so good for you, especially if you're an underlying ischemic heart disease. We don't know really. If we do the recommended amount of activity, surely it's good. But the studies haven't shown what would happen if we do extreme activity. Will the risk go down even further? Will it mellow out, or may the risk even increase? And certainly, if we have an underlying ischemic heart disease, sudden cardiac death increases parallel to the intensity. And the triggering effect of physical activity could be 2 to 56 times if you have an underlying ischemic heart disease. And all the aggravating factors during exercise is you know them already. The stress, the platelet adhesions, the electrolyte disturbances, the heat, the altitudes, conditions like swimming, and then doping and drugs, of course. So why do we need recommendations then? This slide here coming from the 10K midnight run in Stockholm tells it all. In this year, it was 2 years ago, we had 2 deaths in the same race. And this is 40,000 people running, but these things are happening out there. And we need recommendations. And that's always, in this group, is ischemic heart disease. So ischemic heart disease is the main cause of deaths in people over 35 and in people in association to exercise. And also, from newer knowledge, already from the age of 25, it may be the most common. 43% in the US Kings County study of the athletes between 25, exercise-related deaths, I would say, between 25 and 35 were due to coronary artery disease. And just shortly, briefly, to say, to find these athletes at risk then, do we have any strategies? There is a screening recommendations coming from the European Society of Cardiology that says that you should do pragmatic screening according to the intensity, level of the intended physical activity, the underlying risk profile, and the habitual exercise level. That is to say, if you are a well-trained, fit person doing badminton 3 times a week, you don't have to do screening to be in a chess competition. On the other side, if you're heavily overweight diabetic with hypertension, you might not be such a good idea to ultramarathon next week. So, you have to consider the different options there. And this is outlined in the... If this works, we don't know. But there are some promising data coming from South Africa that have used this model. So, the current recommendations, what does it say? It's coming from 2005, from the section of sports cardiology, and it's a recommendation for competitive sports in athletes with cardiovascular disease, and one part of that is the ischemic heart disease. And looking at the ischemic heart disease might be difficult for you to read everything here. It's differentiated into athletes with known ischemic heart disease with a high probability of events, and no competitive sport is allowed. And if you have athletes with ischemic heart disease with a low probability of events, you might be eligible for low to moderate dynamic and low static sports. And what is that? That it's lined up there according to the Mitchell criteria up in the right-hand corner, saying that, of course, the obligatory, what we're talking about, the rifling, the shooting, and so on, but also table tennis, doubles tennis, and so on might be allowed. But if you have risk factors and the exercise test is negative, you're eligible. And also if you have a low risk profile, you don't need any further risk stratification. So this is the old recommendations. And mainly it says that if you have ischemic heart disease, you might not be eligible for competitive sports at intensive sports. So even if you had a prior ischemic cardiac event, had your stenting and so on, according to the current recommendations, you're not allowed, depending how good you are afterwards. So what has happened since 2005? The activity and patterns and trends in the population have changed in the last 10 years, actually. The ethical aspects of eligibility has been questioned. I mean, can we really, on the basis of what we believe, say that people should stop activity, or should we be more permissive when we don't know what will happen? There's also new assessment and imaging methods available, and there's been a lot of talk about why don't you use this method, why don't you use that biomarker, and so on. But do we really know enough to change? And also subclinical disease could now be identified more readily than before. So we think it's time to update the recommendations, not only on every other cardiovascular disease, but also certainly in ischemic heart disease. Just going for the trends of activity, the recent Eurobarometer survey, this is a telephone questionnaire of over, I think, 25,000–30,000 Europeans. And I'm proud to tell you that Sweden will be the country where most people tell you they are doing sports activity. 91% of the Swedish population say they are sporting active. Do you believe that? I don't. But there's a great social desirability to say yes to that question in our country now. So in other countries like Malta and Bulgaria, there were only 15% saying they were doing sports. So you have to consider that people may be more active in mass. Indeed, I think they are. I mean, many people do take place in these kind of activities in our country and in many other European countries. But at the same time, showing these overall physical activity patterns. This is what happened since 2005 until 10 years forward. You can see the trends are going down, and this is also the prediction for the future. This is occupational physical activity. This is travel physical activity. This is household physical activity, all going down. The only line which is going up is sedentary time, sitting time. And we have this prediction that people will be more sitting and less active in their leisure time, but possibly doing a little more gym classes and running one or two races, right? So we have the overall picture doesn't look that great, I would say. So we will have older athletes and less fit athletes, and this is already a fact. Looking at the last 10 years, or this is actually 15 years now, in leading a race, which is a 30-kilometer cross-country race in Stockholm, which is harder than a marathon, I would say. The participants are older, and they run slower, which is a sign that the athletes who are competing are less fit, and they have higher risk factors. So we have an underlying problem here. And we have the trends. High-intensity interval training, right? It's big here as well, I believe. And now they tell you it's even better for the diabetics because it's better for insulin resistance. It has been shown in the lab. But in practical, as a practical cardiologist, it may be just the patients I have with diabetes who are not the ones who can do this because they have underlying heart disease or subclinical heart disease. So this might be, I mean, we have to really consider what's happening out there. And proposed screening tools for ischemic heart disease has been new on the market, so to speak. They're not really new, but they are proposed to be introduced in recommendations. The biochemical markers, we have NT-proBNP or CRP. All these has been suggested to be included. Why don't you include echo? Why don't you include scintigraphy? Why don't you include CT angio in everybody, calcium score, cardiac MRI, and so on? So look at just a few of those. I mean, first of all, the resting-ECG is not very good for finding ischemic heart disease. We all know this, so this is an established fact. So we have to use something else. But what about we know more about calcium score now. We know that, I mean, in the years since the last recommendations, we know that absence of calcium score, I mean, very low, is associated with a low risk for future CV events. So we also know that the progression of coronary artery calcium score predicts all-cause mortality. So I mean, we know something here about coronary artery calcium. But then, when we look at coronary artery calcium in marathon runners, as been shown before today in the study by Merlinkamp, it's been shown that the marathon racers, even though they had a lower risk profile, at current, they had a higher coronary artery calcium score. And that has been interpreted as maybe marathon running will increase inflammation and will increase coronary artery calcium score and give them more coronary artery disease. Or, as been suggested, that there's been an over-representation of ex-smokers in this group. And in my country, we see many people with a lifestyle who wasn't that very good, who's been very, very active in different master events and so on. Three of the top triathlon people in Sweden has been formerly very heavy and obese. So we have to consider maybe the history of these patients. So the role of CT angio then, yeah, it has an additional advantage. I mean, it's out there, it's available, and it's give additional information to the usual coronary angiography. And it may show you the coronary artery plaque burden. So this is great. The disadvantages would be still the cost and the availability, in some places radiation, and we don't have the normal values, do we? So how do we use this information? I'll get back to the SCAPIS study in a moment. What about BMP then? I mean, as an answer to stress, the cardiomyocytes express both BMP and pro-BMP into the circulation. And we can measure that, and surely, I mean, both these has been shown to be predictive of heart failure, and also to be prognostic in stable coronary disease, ischemic heart disease. Could it be used in practice? Yet it has been done in the leading a race again, looking at the racers who are a little bit older, up to 60 years old. They took the NT-proBNP in 185 runners who were over 60 years at a mean age of 62. And 15 out of these 185 were positive, and of these 15, 4 were had a severe disease. I mean, we were looking at ischemic aortic aneurysm, severe heart failure with atrial fibrillation, and severe coronary artery disease needing bypass, and the fourth guy died during follow-up. So these guys were all on this lineup, wanted to compete on the starting lineup, saying they were symptom-free. So BMP might have a role. But there is a lot of remaining questions still to use in the recommendations. These have a place, but there might be the cornerstones we can use, because what recommendations do we give somebody with an increased coronary artery calcium score in the practice? Anyway, should they be less active, or should they be more active perhaps? I mean, we don't know that. What about eligibility for sports, yes or no? And how do we use the NT-BNP in the mass screening? Is it feasible to do that? Blood tests before everybody runs and so on? And how do we treat, or do we treat somebody with asymptomatic coronary plaque on CT angio? What do you do in clinic if somebody has a plaque which is non-severe and is totally asymptomatic? Do you put the whole treatment schedule in? Do you advise them to do more sports or less? I mean, what do you say? So this is really not there yet. We have lots of things to do. One study which might give us an answer, we're proud to have that in Sweden now, is the SCAPIS study, Swedish Cardiovascular Bioimage Study, which will include up to 30,000. I think now with the recent grants coming in, it will be 30,000 people from the middle-aged, 50 to 65-year-old. One of the biggest studies we've done in our country in this. Started in November last year, and the pilot study is already performed, and the papers are soon coming out. But the big study will include the middle-aged population, where all these studies are done. That could be the spirometry for lung function, that would be submax exercise text, accelerometer, that would be CT on everybody, CT angio, coronary artery calcium score, and Doppler of the carotids and so on. So that might give us a reference of the normal middle-aged population, runners or not runners, because these will include unselected population, which is stratified socioeconomically. And that could be used as a reference to the veterans in London, and we hope to do that together, I think. So what is the rationale for the new recommendations? We are trying hard from the European Society of Cardiology group to say that the section of sports cardiology, these recommendations for ischemic heart disease in sports must be to minimize the risk, of course, but also not to discourage patients to be active. And the rationale and the big divider would be the existence of myocardial ischemia during exercise or not. Still, the big divider. And when there's no scientific evidence to exclude somebody, the aim is to be more permissive than before. And I think that's something that has crept up in the last years. So what is included? In the new recommendations, there will be included the ischemic heart disease, the proper ischemic heart disease, so to say. Even the patients with risk factors for ischemic heart disease or subclinical ischemic heart disease. You might show a aortic plaque, or you might show a carotid plaque or something, something that gives a clue that you might have subclinical disease. Or you might have an event, so you're established ischemic heart disease. And these could be divided into higher and lower risk. But also other entities will be included, which are associated with myocardial ischemia, like myocardial bridging, like coronary artery anomalies, like syndrome X, and like coronary artery spasm. And these were also included in the last recommendations. And these can all, I mean, the problem here in these patients is this, athletes would be myocardial ischemia as well. So what will the new recommendations look like? And this is the writing group over there, so big group of people from the section. But it will include recommendations for risk assessment and eligibility, of course. And the key again would be the signs of myocardial ischemia. And the exercise test will still hold a very key in this. And you might get to myocardial ischemia showing from other positions as well, using other methods, but the exercise test will still be a key in this. Although with all its limitations, it has several advantages. And the recommendations on proper exercise training and follow-up will be included, which is new, and also the subclinical ischemic heart disease, which we treated mainly as athletes with ischemic heart disease. And so I would stop here by saying that the future, I mean, we will have these recommendations coming out, and I can't give you the details of them. And they will not be that different from the old ones, but they will differ a bit, like the points I had here. And they will be more permissive, I would say, than before. So you might end up having a person with established ischemic heart disease, which has been stented, and there's no ischemia on follow-up. There is no on exercise testing, no arrhythmias, no blood pressure fall, no ischemia, and symptom-free and so on. He or she might be allowed to do sporting activity again, which is not what the old recommendations said. And for the future, we must achieve all the benefits of activity, but without, put the athletes at too much risk. So, and just to stop with the new assessment tools for this disease, there are many. They have a rule, but they need to be evaluated more and to improve the recommendations next time around, I would say. So thank you very much.